Jing 2018. Historians traditionally viewed the 19th century public health movement as a direct response to the series of cholera pandemics of the period. The first epidemic to reach Europe, the first pandemic of 1817-23, petered out after it spread from India to the Middle East and Northern Africa, certainly raised consciousness about communal disease. From 1827, when the second pandemic began to spread out from its ordinary home in eastern India, Europe watched anxiously as the disease moved ever closer. Many European nations sent delegates at some stage during the 4-year waiting game to investigate the disease and make recommendations on how best to prevent its reaching Europe. There were two main sources of concern. First, the disease was new to the West, an exotic disease with which only tropical colonials would have had previous experience. The second pandemic moved throughout Europe and into North America, and introduced the medical profession to a serious new disorder with alarming symptoms and mortality rate. Its newness and epidemic character led many commentators to speak of the return of the plague, all the more disturbing since old-style bubonic plague seemed to have disappeared permanently from the West. Second, the pattern of spread was puzzling. Two polarized explanatory paradigms were current to explain epidemic diseases, miasmatic and contagious. Miasmatists argued that communal diseases were spread through the air, the result of atmospheric conditions or particles contained in the air. The most commonly postulated source of the disease was rotting organic matter, such as refuse, feces, anything, in fact, that was oppressive or smelled badly. The power of this paradigm is easily appreciated. The air is a common feature of a locality and could explain why many individuals might be affected. It also helped differentiate healthy from unhealthy localities within a paradigm that would have been familiar to the author of the Hippocratic treatise Airs, Waters, Places. It was the dominant explanation for the complex of diseases, many of them unknown in the Old World, which Europeans encountered in tropical areas. They were generally known simply as diseases of warm climates, and oppressive heat and humidity and exotic vegetation were so obvious that evoking them to explain disease patterns made rational sense. Contagionists postulated that epidemic diseases were spread from one afflicted individual to another. This could account for many aspects of epidemic disease, such as the fact that people nursing sick individuals often came down with the disease themselves. Contagionism justified the instinctive wish to avoid contact with people suffering from dangerous diseases, and underlay the practice of quarantine. It also preyed on collective fears of the origin of plague and other frightful diseases in marginalized groups. A middle position, contingent contagionism, was less hard-line, and more easily adaptable to the anomalies that both the main positions had difficulty explaining. Contingent contagionists argued that diseases might be either miasmatic or contagious, depending on the circumstances. For instance, a disease might enter the community through corrupt air, but some individuals could develop the disease in such a way that they then became foci of contagious spread. This mixed the categories in ways that the observations required, and covered all fronts. Unfortunately, theories that explain everything often explain very little. A few diseases, such as smallpox and measles, were always viewed as contagious, but most communicable diseases had patterns of incidence and spread that were sufficiently complicated to leave much room for debate. Germ theory was later to offer a new paradigm for communicable and epidemic diseases. Although there were still anomalies, why could two people exposed to the same source of infection react in such different ways, so that one came down with the disease and the other remained completely well?